Hello again. Thank you again for the invitation to speak here. I want to talk today about treating venous cava superior syndrome. As Bruno told me, in your country it's mainly for ISIS access. In my country it's more about treating symptomatic malignant stenosis of cava superior syndrome. But the treatment options are both the same, so I think we can have some theoretical things and go through some live cases to show you some treatment options, invascular, interventional treatment options. So the etiology of the cava superior compression or occlusion is from the literature up to 85% related to melanoma. It's a non-small cell lung cancer and Hodgkin lymphoma who are very, very central in the mediastinum, occluding this means. But of course, it's also device related to pacemaker leads, ICD leads, and dialysis catheters, port catheters, and sometimes also treatment related. There are very rare cases with fibrosing mediastinitis due to virus infections or some vasculitis disorders. The main symptoms of the patients are, of course, a venous hypertension proximal. That means venous hypertension in the head and the arms, swelling of the upper torso, of the neck, of the face. You see the patients coming to you with a very dilated, non-collapsing veins. They have a really red face I have today because I had sunburn, but those have really impressive red faces. And of course, due to the edema of the larynx, they present with hoarseness, they have cough, stridor, they have really dyspnea, some have dysphagia, and in a very rare case, with very acute onset of the symptoms, you can also have neurological symptoms due to the cerebral edema. Here from a review from 2011, just recognized incidence of the symptoms I told you already, and the symptoms itself are very compromising in the patients. Actually, they're not fatal until they do some hemodynamic compromising, really severe neurological symptoms, or laryngeal edema, so the patient can't breathe anymore. Normally, the symptoms occur within 2 weeks after the occlusion of the node occurs, and there's some relief due forming collaterals through the axillaris or hemiaxillaris veins. This will take some time, and in patients with melanoma under treatment with radiation and chemotherapy, they can take up to 12 weeks. The problem is that those patients are also on a palliation, so you have to treat them just to give them some relief. Without neurological symptoms or hemodynamics alteration, the cava superior compression is not fatal, but it's very compromising. Okay, so I have brought you some cases for successful treatment of the cava superior syndrome. Just to give you an idea how you can go on, how you decide what kind of stent you want to use, and what other kind of treatment you want to do and what you want to achieve. The first case was a 49-year-old male patient who had a suspicion of lung cancer almost 6 months ago in the hospital. He failed to go to the specialist to check this because of his ongoing alcohol and nicotine abuse. But then he presented in the emergency department due to a very severe dyspnea and clitora. And then he told us his symptoms began 6 weeks ago, and he told us this, and he was a very fair fight that he had a non-small cell lung cancer. But during his course in the hospital, his symptoms worsened, and then he was presented to our cath lab, and we started, first had a look on the CT scan, so you can see here the huge tumor in the mediastinum, and you can see both brachycephalic veins on the side of the tumor, the left one occluded, and the right one is here rather compressed, and the outside of the tumor, here the filling of the right atrium. The angle we performed from the arm, so we had the idea that maybe we could easily pass this here through, and here's just an injection of contrast, and you see here how the tumor compresses the superior vena cava. We passed this from the arm through, then snared the wire and came back retrogradely. We dilated and found no really severe stenosis. So this was just the expansion of the tumor compressing the vein. So we just need something to keep the vein open. So we choose to implant a nitinol self-expanding stent. And after we did that, we found some old traumas below here, so we put another one. And this was the final result. And the patient, who was very unstable at the table, he had to keep the cath lab table, really the head up, felt an immediate relief. And we found it was a good result. But then he came a bit later again, 3 months later, with an immediate onset of the symptoms. And anyone said, yeah, now you have a stent thrombosis over there. We thought it couldn't be like this. And as we found, they had a progression of the tumor proximal to the stent. So here again, a very high-grade stenosis of the right brachiocephalic vein. And of course, we wanted to help the patient because it was really compromised. He couldn't lay on the table, so they had full anesthesia. You see here the tube from the anesthesia. And the guy who did this said, okay, did work quite well with the nitinol self-expanding stent, and put another one. And as you can see in the side view, in the front view, it both looked nice. In the side view, this stent wasn't really open. So in this case, you have to treat it and then keep it open with a balloon expandable stent. In my opinion, a little too small, but for this situation, it solved the problem, and the patient again had relief and could go on with the rest of his life. He died 6 months later, but he never had again any symptoms. Another case with not malignoma-induced cava superior compression. He suffered over 1 year from suffocation, dyspnea, swelling of his arms, and a severe cough early in the morning especially. He went into Shuttle Hospital. He had a coronary artery disease, a diabetes, and renal failure. And everyone who was presented to told him, yes, he had some heart failure, he had some renal failure. But it didn't solve the problem. He was presented in the university hospital, and they said, yeah, you have quicker edema. He also had some gastroscopy due to dysphagia. They found cervical varicosis. Actually, this was due to collaterals because of his compression of the vena cava superior. There was made a CT, and on these slides you can see here the open cava superior, then this tiny hole here is the rest of the cava, and then opening of the right atrium. Here the angiogram from below and above. At this stage, this small hole was occluded. So if we wanted to help him, actually he was getting his renal failure became even worse. So he was scheduled for some AV fistula. So you have to treat this one to keep it, to have a good dialysis from the arm. So what we did, we canalized from below with a soft hydrophilic wire, and we dilated the lesion and found a really severe stenosis which couldn't be opened up. And of course, with such a lesion, you cannot put a self-expandable stent that will not stay open. So we put a balloon expandable stent. It's a Parma stent. You have to get the stent without a balloon. You have to crimp by yourself on the balloon. And the problem was that it was not inserted properly. I showed the next how you do it right. The problem was here that the stent was a little too low. And when we wanted to pull the balloon back and pump properly, everything came down. So this stenosis was here. Here's the right atrium, and as you can see here, the whole balloon with the stent comes down. Now you have a half-open stent in the right atrium. That is not good. Either if you call the cardiac surgeon, or you can resolve it. We tried first with a balloon at the proximal end, at the distal end, next to the stent, one balloon inside to pull it back to the lesion. That didn't work. We tried to catch the balloon from below, tried to pull it back. That didn't work either. So what we did was we just used the snare, which we formed from an 18 or 14-inch wire, and we managed to get the wire around the stent, so we could compress the distal part of the stent again to pull it down. The problem was then pulling this stent down, and the orifice of the right atrium to the inferior vena cava, the crista terminalis, prevented from pulling back the stent, so the struts dislocated and we didn't get it out. That was really tough. We already were at the phone for the cardiac surgeon, but then we managed to pull it out. Here it's in the inferior vena cava, and then we implanted it, the stent in the right common iliac vein with an hopefully good result. We postulated the lesion, but he had to come back, and he came back 6 weeks later, and he told us, yes, I had a relief of symptoms for almost 2 weeks, and then it was back again. And as you can appreciate, on the first movie, the stenosis came back maybe a week or so. This one has to be treated, of course, with a stent, and on the second film you see how to do it properly. You open up the palmar stent inside, and even if it's half inside of the sheath, so they can really press it into the lesion, and you pull everything, and if you get really the feeling that it's really hard inside, you pull the sheath back, and the stent is implanted. And here, the final result after stent implantation shows a very good result, and it's still open. Now we get an AV fistula with a very good working dialysis. So this was a non-malignant case. Again, we have also our patient with a cava supracompression arm from malinomas. So here's a patient presenting in the ER with some edema, with dyspnea. Here there was a first diagnosis of lung cancer done, and they started some radiochemotherapy and hoped that will resolve the problem, but it didn't work. So he was referred again to our Center for Interventional Therapy of this cava supracompression. And with this case, I want to show you that it's important to have a look at the CT scan you have to take before we treat those patients. Normally, you have only a chance to go up to the right brachiocephalic vein, but in this case, here you see the tumor. This is the left brachiocephalic vein. That is the only one to stay open. The right one is not open. Then you have a huge thrombus in the orifice of the right atrium. So this was our plan, just to go from the groin and have a look. And when we did this, the wire went easily up to the right brachiocephalic vein, but there we injected some contrast and found almost thrombus. So it's not very helpful to connect these veins to the right atrium because there's no flow because of the thrombus, and you will not get out this thrombus very fast because this patient even was compromised, lying not very stable on the table. So what we did, we punctured the left arm, and as we planned from our CT scan, we injected some contrast. Hopefully you can see there's here a little contrast flowing down, not really fast, but it wasn't due to the thrombus here in the right atrium. It wasn't possible to get in there. So we had to pull the wire from the arm to the groin, snare it there, and then return the wire and treat the lesion here. We pre-dilated and found again a very high-grade stenosis, which doesn't open very well. So again, we wanted to implant a new extendable palmar stent, and here again the right way sheath protected. Open the first part of the stent, then pull it back, and then the stent stays in the right position. After this stent implantation, we found some residual thrombus here in the brachiocephalic vein. So this is not a stent for keeping the vein open, just to fix the thrombus that is there, so it doesn't go down to the right atrium. And again, after this procedure, the patient feels immediate relief. This is very impressive, and this is only a black and white picture, but those patients really, the edema of the head will relieve within 24 hours, and they're feeling very much better. Our patients, if they don't have so much high thrombus, we let them home with aspirin and low molecular weight heparin. If there's huge thrombus mark that we have to pull out with some thrombectomy device, then we start with full intubulation for 3 months. Accordingly, for their underlying disease, you have to be sure of this. Okay, and the last case I want to show you was a patient with an with an AV fistula on her right arm. 48-year-old, she was on dialysis for 4 years, and she had some recurrent occlusions of the AV fistula, of the veins of the arm. She had in another hospital several trophectomies, several intervention of the vein, and was referred to our center again of a failure for dialysis and a massive swelling of the right arm. And in those cases, we have to check the whole pathway from the arterial to the shunt to the vein. And so we get some arterial access from the groin, inject some contrast in this labial artery, and here you can see the artery going down, the systolic vein coming back, and then here's a stent already found in another hospital, a little drain to the supravena cava and the right atrium, but most of the contrast is going back to the brachial vein to the arm. So the problem must be here. We also looked at the distal shunt anastomosis. Here we have again some stenosis. So what we did, we get a venous access from the groin, and I hope you can see it very well. But here are 2 layers of balloon expandable stent in the proximal part of the venous placa. This is actually not very good because in this part the vein is directly behind the clavicula, and when you're moving the arm, the stent is currently compressed, and in this region a balloon expandable stent is not a good solution. We recanalized it, and as you can see here, the balloon going up, there's still some waste in the balloon, so there's a really hyperplasia here, which you really have to treat. So what can we do here now? There are 2 layers of stent, recurrent reclusion, recurrent stenosis. What can we do there? We decided to implant stent graft. It's a fluency stent graft from Bard. For 2 reasons. First, it's a nitinol system with wires, so it's self-expanded. As the arm is moving and the vein is compressed, it will gain its original shape. And the other reason it's covered, because then the hyperplasia will not go back down, back into the vessel. So hopefully this will stay open. This is a nice result, and I think we solved the little old lady and prevented her from further interventional procedures. Of course, we related the stenosis down there here as well, but in the end, it was a very good result. He had some huge arteries and veins, so we thought this residual stenosis was be enough in this case. So when I could put everything together, I can say the interventional treatment of malignant compression or occlusion of the supravena cava is very efficient and has a very good short and long-term symptom for palliation in those patients, because they don't have many time anymore. In benignant obstruction, you have to really consider treating those lesions in accordance of the duration of the symptoms. If they're presenting a patient who has only symptoms for 2 weeks, you should give him some time. Maybe he has collaterals. If he doesn't have a need for any dialysis or pacemaker implantation, you don't need to treat it. But if you need an urgent open vein because he had a left ventricular dysfunction and some biventricular pacemaker or something else, then you should consider treating this patient. And of course, interventional treatment of this lesion is a good option to reduce invasive surgical treatment. The choice of the stent depends on the lesion. If it's a short lesion, if it's not opening very well after balloon dilatation, you have to have a balloon expandable stent. If it's only a compression from outside, maybe an arterial stent, or if it's a moving segment, an arterial stent is the best. And you should consider always you have a thrombectomy device or a big guiding catheter to aspirate the thrombus outside of the lesion. Thank you very much.